Hello, everybody. Welcome. We are so glad that you are joining us. We're going to give everybody just a minute to get in the room. I see you guys all joining, so we're really glad you guys are here. Welcome to everybody that's just hopping into the room. I'm going to give everybody just another minute or so here to get logged in and get set up. We still have people walking in the door, so I want to make sure we get most everybody in, and then we'll get started here in just a minute. Welcome to those that just joined us. We're very glad that you are here. My name is Missy Gilliland. I am the Learning and Development Manager here at Symmetry. We're very happy that you decided to join our webinar to come learn a little bit about OASIS and some of the changes that we expect to be coming down the road. As we get started here, if you have any questions, please use the question and answer down at the bottom of your screen. You can type in any question that you have, and as we have time at the end of the presentation, we will go back and answer those questions. If we do happen to run out of time, we will email out those answers after the presentation. I will be attaching the handout in the chat feature as we get started here today. If you have any issues accessing the handout, just let me know in the chat and I will resend it out to you. So again, welcome everybody. I think we have most everybody in the room. So again, if you have any questions, please use the Q&A down at the bottom of your screen. Ask whatever questions that you have as we get to the end of the presentation. If we have time, we'll get to those questions for you. And so now I'm happy to introduce Griffin. She's going to take us through a understanding of high-level OASIS changes. So with that, Janan, I'll hand it over to you.
Thanks, Missy, and thanks everybody for joining. I hope you didn't come today thinking you were going to get a full OASIS education. We're just going to talk about the high-level changes, and then we're going to talk a little bit later about the series in general that we have coming up with OASIS. So our objectives today is you should be able to identify the differences in your OASIS D1 and your OASIS E, that you'll be able to understand some new items for behavioral health and transfer of health information, and you should be able to understand why the new items are being introduced. So we know pre-COVID, it seems like so long ago, doesn't it? That we had some items, I think even with OASIS C2, that were part of the Impact Act that happened in October 6, 2014, that they passed the Impact Act item, which is Medicare post-acute care transformation. And what that is supposed to do is to standardize certain post-acute care questions or data to improve Medicare beneficiary outcomes through shared decision-making, care coordination, and enhanced discharge planning. So to have that availability to discharge planners, is the patient going to the appropriate level of care? With the Impact Act, CMS had some meaningful measure priority areas, and that was to promote effective communication and coordination of care, to promote effective prevention and treatment of chronic disease, to work with communities to promote best practices of healthy living, to make care affordable, to make care safer by reducing harm, cost in the delivery of care, and to strengthen person and family engagement as partners in their care. Again, Medicare is really looking at trying to align the post-acute care space to make sure that we're doing good communication, good handoffs, and good coordination of care for the patient's benefit. We know with the Impact Act, there are some quality measure domains. Some of them we are currently measuring. Some of them we will measure with OASIS. So we have skin integrity and changes in skin integrity, and this has to do with your pressure ulcers. And remember, when that item came into effect, we had to take the first skin assessment. We couldn't use that 5-day window anymore for our start of care for that pressure ulcer. And so it was to align with the other post-acute care measures and their quality, I mean, what they quantify as the pressure ulcer. It needed to align across the whole entire post-acute care system. Functional status, cognitive function, and changes in function and cognitive function. Medication reconciliation, we were actually the first ones to do medication reconciliation. There will be a little bit of change to that with OASIS, and I'll show that to you in just a little bit. incidents of major falls, and then a new one also for us will be transfer of health information and care preferences when an individual transitions. It is also for resource use and other measure domains. So we look at the resource use measures, including the total estimated Medicare spending per beneficiary, how many patients are discharged to community, and then all condition risk adjusted, potentially preventable hospital readmission rates. So CMS did a study, as CMS does, and let us know what they thought the estimated time for each of the OASIS would be. This happens every time they change the OASIS items. What is the administrative burden or the clinical burden to agencies? So you can see here it's broken down into time points. So for starter cares, you have 158 items. For D1, you will have an additional 59 items under OASIS E, but they will also remove 14 items. So there's a net change of 45 items. And we'll talk a little bit about that. So the total number in OASIS E starter cares is 203. CMS estimates that will be about a 57.3 minute to complete the OASIS. That's not completing the consent forms, all of the other things that we have to do, go over if you're accredited, go over your accrediting body, go over your COP type of information. That is just for the OASIS. For the resumption of care, there'll be a total of 172 items, and that's estimated to take about 48 minutes. Here's the interesting one, and I'm going to talk a little bit more about this at the end. Your follow-ups or your research really only have 44 items in it. And it's estimated, and remember, some of that's going to be your demographic information. The estimated time to take it is only 13.2 minutes to administer it. And so we're going to talk again a little bit about that. Transfers of care, there's 22 items and it's supposed to take about 6.6 minutes. Death at home has 9 items and it should take about 2.7 minutes. And then discharges have 146 items and should take 40.2 minutes. If we look at the clinician burden cost from OASIS D to OASIS E, there's about a $340 million difference. So about $30,000 per home health agency. So if you think about the time spent along with all the education, that's where they're coming up with that number. So what are the major differences in OASIS E? They've added items into 3 categories. So we have the standard patient assessment data items, or the SPADES. We have a brief interview for mental status, or the BIMS. And we have social determinants of health. And so while we've had to have those social determinants of health as part of the conditions of participation, it wasn't built into the OASIS. And so there are some items now that are built into the OASIS that you will see that we were already supposed to be collecting. It's just now in a standardized format for data collection. So to be included in the OASIS data set, item must meet one or more of these criteria. It either needs to calculate a measure for the HHQRP, or the Home Health Quality Reporting Program. It must contribute to a calculation of the payment. It has to either be used in the Medicare survey process or calculate a measure in Care Compare. And so really when they're looking at OASIS items, it has to fall into one of these areas. Now, some of that, again, is demographic information that's part of the OASIS. You have to have that to know which patient it's with and what category they're in, they're in the 70 to 75 age range, those type of things. So we have to remember that right now that the OASIS form in and of itself is still in draft. It's in the comment period, or it's after the comment period actually has closed, but waiting on the finalization by the OMB. Don't think there'll be a lot of differences from the draft, but there may be a few. The big difference I see in the actual printed copy is there is a drastic change in the formatting. And not only the formatting, but how it's organized. I don't know what that will look like in an EMR. The EMRs may not really look any differently, but it will be hard to tell until the EMR rolls that out. The items are sequenced differently on the form. Some items are separated, such as race and ethnicity. In the revised OASIS draft, patient declines to respond was added as an option to the social determinants of health. And so again, there are a lot of new items of social determinants of health, and the patient can choose to not respond to those. So if we look at the different sections of OASIS, again, broken down very differently, and it's broken down alphabetically. So we have A, or administrative section, and we're going to go through each of these sections in just a minute. B is hearing, speech, and vision. C is going to be cognitive patterns. D is for mood. E is for behavior. F is preferences for customary routine activities. We have our G and our GG items. Those haven't changed, our functional status and functional abilities. H is bladder and bowel. I is your active diagnosis. Notice how far down in the form it is. Active diagnosis is usually toward the beginning of the form. Again, how the EMR set it up, I don't know. J will be our health conditions. K will be for swallowing and nutritional status. M is skin conditions. N is medications. O is special treatments, procedures, and programs. And Q is participation in assessment goal setting. There are no L and P sections, and I don't know why that is unless they've left them for future expansion. So if we look at our difference in our sections from D1 to E, you can see the difference and how they're set up. So you have your patient tracking system now, which is your demographic information, your medical record number, the physician, those type of things. It will all be under the administrative information going forward. And just a side-by-side comparison of actually how it looks. And I'm going to show you how the forms look in just a moment. There were some items added, again, ethnicity, race, language, transportation, provision of current reconciled medication list to the subsequent provider at transfer, and reconciled medication list to subsequent provider at discharge. And then we have a current reconciled medication list given to the subsequent provider. We did delete the race and ethnicity only because it's split up into two different things. You'll also notice that we went from an M item in race and ethnicity, and now it's under the administrative section, so it's an A item. So probably just like you, I'm going to struggle with things like M item, M whatever number I'm talking about, right? It may not be an M item going forward. It may be a different letter. Here are some items also deleted. Your M1030 therapies is deleted, M1051, 1056, and M1200. M1200 has been deleted, yet it's been replaced by B1000 with a little bit of changes in verbiage, not a lot, but a little bit. You'll also see here things like health literacy. We see some cognitive type of assessments that we'll have to do under the C's. D is going to be your mood, and J is going to be your pain category. They will eliminate M1242, frequency of pain interfering, but they're going to replace it with 3 pain items. Also, the depression screening M1730 is changing, but it's changing to an expanded depression screen. M1016 and M2401, just M2401A, which is the diabetic foot care. You'll also see that they added the J section, again, the pain, the K, which is your nutritional approaches, your N, which is your high-class medications, and your O section, which are going to be your special treatments. So let's look at that administrative information, that section A, and see the differences. So here you'll see how the formatting is a little bit different, not a lot, but a little bit different. And again, it may not look any different in the EMR. You'll see here where the race and ethnicity were together, and now they're split apart. And you can also see that they can check all that apply. So you may have a patient that has a mixed ethnicity. Maybe they're part Cuban and part Puerto Rican, and they can mark both of those if that's how they choose to identify themselves. Same way with race. They may have a mixed race and they may choose to have more than one race. Your current payment source, really the only thing that's changed is the formatting. Again, check all that apply. The guidance is still the same for all of that. Again, some formatting changes. You're going to see the formatting changes throughout. So the M0102, 0104, more of a boxed type of format and not necessarily how they were under D1. You'll notice that the M1250 is added here. I mean, I've already done it. A1250 is added here for transportation, and you're going to check all that apply. And so let's look at those. It's yes, that transportation or lack of transportation has kept me from medical appointments or from getting my medication. Yes, it has kept me from non-medical meetings, appointments, work, or from getting things that I need. No. Patient unable to respond and patient declines to respond. So again, they can decline to respond to any of these social determinants of health. Why is this important, do you think? If we think back to the conditions of participation, we kept saying we need patient plan of care that's specific to the patient. Does it matter if the patient can't go get their medicines or go to the doctor? It certainly matters. It also may trigger us that maybe the patient needs a social worker referral or that we're doing something about it. So if we've identified that the patient has a need for that, we need to be doing something about it. And I'm sure nobody's told me this, but I also try to think of survey issues. I'm sure if a surveyor sees this on your OASIS that yes, transportation or lack of transportation has kept me from medical appointments, they're going to want to see some sort of follow-up by the agency that they're trying to do something to alleviate that. The next new item, other than the formatting, we can see that there's some skip patterns with your discharge disposition. And remember that last year, maybe year before, time kind of slips away with COVID. It all is kind of blurred together, that they changed what is with and without formal assistive services. Remember, the with formal assistive services is really if the patient is transferring to like another home care agency or to a hospice. And that's going to trigger one of the new items, which is the reconciled medication list. And I mentioned that earlier. You have A2120, which is provision of a current reconciled medication list to a subsequent provider at transfer. And then 2121 is that reconciled medication list at discharge. And so depending on the skip pattern, you will have to supply that at transfer and discharge. You've already had to do it under the conditions of participation, but now there's an OASIS item that kind of forces that. Now, what comes next is once we have that, how are we transmitting that to that subsequent provider or to that patient? Was it given by electronic health record? You know, are you in Epic and that is just given in the electronic health record? Are you in some sort of health information exchange organization? Verbal, it can be verbal, in person, telephone, or video conferencing. You can have somebody at your agency calling and going over that reconciled medication list with the provider. But even more importantly at discharge, and we'll talk about that on the next one. Is it paper-based or are there other methods? So just really think about the processes you may need to put in place because your clinicians may not know how that's going to get to the provider. It may be somebody in the office that's doing it, and does it need to be consistent? Also, let's think about that reconciled medication list of patients at discharge. Now, they should have a medication list in the home, but the guidance tells us that that medication list to the patient needs to be in plain language. So if it's just a list of medicines, it may not necessarily be in layman's terms. to where we have to do it? And if so, how are we giving that to them? Are we giving it to them verbally? Are we saying instead of losartan 50 milligrams once a day, are we saying, hey, your white round blood pressure medicine you take in the mornings? Is that what you're saying to the patient, or is that what you're writing out to the patient? And what are you doing? How are you communicating? And my suggestion would be that you need to have a standardized way to do it. Otherwise, it's going to get missed. Now, if you're a reviewer on the call and you're the OASIS reviewer, that's going to be an important piece, right? If they say that it was faxed, do you have confirmation that it was faxed? Is somebody in the office attaching that somewhere in the chart? So the question comes is, why do I need to do a medication reconciliation at discharge? So what that does is ensure that new caregivers or patient and family are aware of any current medications, doses, and the reasons. And it should be ongoing. That medication reconciliation should not just happen at certain time periods. It should happen every time you go in the house. Every person that goes in that house should be seeing if the patient has any new or changed medicines, and then doing a medication reconciliation if that happens. Now, your home health aide obviously can't do a medication reconciliation, but they can certainly notify someone if that medication reconciliation needs to happen. All right, section B is going to be your hearing, speech, and vision. We have several new items in this one. Again, we did away with the M1200 for vision, but we've added the B1000 for vision. And you'll see a lot of it is similar, but not the same. So our choices are: they see adequately, they see fine, see regular newsprint. Impaired is they see large print, but not regular print in newspaper and books. And the older I get, the more I appreciate that. Moderately impaired, this is limited vision, not able to see newspaper headlines, but can identify objects. Highly impaired, object identification in question, but eyes appear to follow objects. And then severely impaired, they can't see vision or sees only light, or they don't have the comprehension and the faculties to be able to answer this question. Above that, you'll see B200, which is hearing. And what is their ability to hear with hearing aid or hearing appliances if normally used? And a few years or a few OASIS ago, they took the hearing portion out, but now they've added that back. And is it adequate? Is it minimal difficulty? Is it moderate difficulty? Or is it highly impaired, absence of useful hearing? Is it one of those patients you walk in the house and the volume is set at 47? You know, they probably have some difficulty in hearing. The next one is B1300, which is health literacy. And how often do you need to have someone help you when you read instructions, pamphlets, or other written material from your doctor or pharmacy? And I know that when I taught the conditions of participation, we talked a little bit about health literacy, again, because you need to have that individualized plan of care. So health literacy is not the same as literacy. So really, personal health literacy is the degree to which individuals have the ability to find, to understand, and to use information and services to inform health-related decisions and actions for themselves or others. So I think of it like a pharmacy pamphlet. I can read it, but do I really understand what all that's saying? Do I understand the molecular makeup? Do I understand all of those things? And so we really need to find out, you know, not I can read on a 5th grade level, which is what a lot of agencies ask or find out, but how does my patient really understand the information that I'm giving to them? They can read it, but can they comprehend it and apply it? Our next section is section C, cognitive. There's a whole new section here that we're going to have to start training our clinicians on. And I say a lot of these items feel very social workery. So you have your social determinants of health. We have these brief interview for mental status, or the BIMS, and then the CAM. I'm going to talk about that in just a minute. But these assessments, I think Arlen is going to go over more in depth in 2 weeks. But basically it's to determine the patient's mental status and how well they can recall things. And so you're going to ask a patient a repetition of 3 words, sock blue in bed, and you're going to then answer that how often they, how can they repeat it back? Can they, if I tell them sock blue bed, can they turn around and repeat back to me sock blue bed? And I'm going to put the number of attempts after the first attempts. They only got 1 word, they got 2 words, or they got all 3 words. Then I'm going to ask them, what year is it? What month is it? And what day of the week is it? Now, there are certain days that I can't tell you what day of the week it is, especially after a holiday. I think it's a Monday when it's really a Tuesday. It just happens. And so you're going to ask those questions, and then you're going to go back to that sock blue bed question and say, okay, remember I told you those 3 words earlier. Can you tell me what they are again? And so then the patient answers that. Then all of those questions, however they're answered, are calculated for your C500, which is your BIMS summary score. If the patient was unable to complete the interview, you're going to enter a 99 here. Again, that's for the first try, only for that repetition of the 3 words, and you're going to put how many words they got after that first try. Your temporal orientation, I've already gone over, but it's your orientation to the year, month, and day. And then after that, you're going to have a confusion assessment method, or the CAM. And this is supposed to show signs and symptoms of delirium, which may be different than signs and symptoms of dementia. So is there evidence of an acute change in mental status from the baseline? Yes or no? Again, a new item. And then you're going to put what behavior was present. Did the patient have inattention? Did they have disorganized thinking? Did they have an altered level of consciousness? So the purpose of this assessment is a standardized evidence-based tool, like most tools are that they add, that enables non-psychiatrically trained clinicians to identify and recognize delirium quickly and accurately in both clinical and research settings. The screening tool alerts clinicians to the presence of possible delirium. And here, I put a link in here for you to watch a YouTube video about how to administer the CAM. Now, it's going to be really important that the patient themselves answer the BIMS and the CAMs and not a caregiver. It needs to be the patient. You may have those helicopter wives that try to answer everything for their husband, and vice versa. The husband may try to answer everything for the wife, but we're going to have to politely either excuse them for the room or just say, hey, really, this is for the patient, and we're not trying to make them feel like they can't answer the questions. We do this for everybody because a lot of people think you're picking on them, right? And so we need to let them know that we're doing this for everybody, and it's not just for them. Okay. All right, our next section is mood in section D. Again, M1730 is going away, but it's changed to D0150. It also is an expansion into the PHQ-9. So if the patient scores a 2 or a 3, then you're going to expand it into and do the PHQ-9 with it, and it's already included. Now remember that patients with dementia can't do the PHQ-2 because you have to have the patient answer this themselves, and you may need another geriatric screen for depression. You're going to add up the total severity score there. And then after that, there is a question on social isolation. How often do you feel lonely or isolated from those around you? And you're just going to give them the options, or they may say, I feel that way all the time. My kids never come to see me. I try to call them, but they're all working and they're very busy. It used to be when I was out in the field, I knew when it was Days of Our Lives time that we had to talk about Days of Our Lives because, that was their social interaction. And then me coming once a week was their only other social interaction. Usually you have those patients that talk to you for, an hour because they just don't have anybody else that they talk to. So we're now going to have to ask them the question, do you ever feel lonely or isolated? And as you start reading evidence of, the older population that may be suicidal, a lot of it is because they are lonely and feel isolated and feel not only lonely and isolated, but they feel like some of their dependence has been taken away or independence has been taken away. The next thing is section E for behavior. It really hasn't changed, just the formatting, and really hasn't changed that much at all. So M1740 and 1745 are both under this section. References for customary and routine activities, section F, you have M1100, that hasn't changed. It didn't change to an F item. It's still M1100 and still basically the same question. M2102, is basically the same, just again, a little bit different formatting. Our G and GG items really didn't change at all, except M1870 moved to a different category. So it's not with the rest of the M1800 items, it's under another category. And there were no changes to the GG items. Everybody's probably very happy about that. Bowel and bladder, section H, really, again, only formatting changes, not a lot. Active diagnosis, again, for you coders out there, we have moved the active diagnosis way over into the middle toward the end of the OASIS now, not toward the beginning. And of special interest, and what you need to start asking your vendor, if you are entering your codes into the OASIS, they may choose to keep this in research. CMS, it is not in the CMS follow-up form, because really we don't need the diagnosis for the claim. Remember that it's not pulled from the OASIS, but again, your EMRs may choose to have it, or they may create another section that you put your diagnosis in outside of the OASIS that will pull to the claim. But that will be something that you need to ask your EMR, is how are you handling this section, especially for research. Health conditions, section J. Again, your 1242 is going away, but it's going to be replaced by 3 pain items. Your M1033 is also under this section, under section J. So you're going to have your pain effect on sleep over the past 5 days. How much of the time has pain made it hard to sleep at night? I actually really like the pain questions, because M1242 is very vague and it's the recent relevant past, and it really doesn't talk about anything besides the patient's activity or movement. It doesn't tell me if it's something in particular. So I really do like the different pain items. So has the patient had trouble in the past 5 days for sleep at night? The next one, has the patient had in the past 5 days trouble participating in rehab? Now, if you're doing an admission, you may not know, you may have to ask, oh, when you were in the hospital or when you were in rehab and they did therapy on you, did it hurt? So you may have to ask that question. On other time points, you may be able to get it just from the therapy notes. And then pain interference with day-to-day activities. And this is going to exclude any rehab because of pain. You have your J1800 item and J1900 items here. And we also moved M1400 under this section. So shortness of breath is also under this section. So again, especially those EMRs that have your comprehensive assessment built around those items, are they planning on moving that whole entire section? Because they can put it in any place they want to, as long as it follows the skip pattern. So really that's going to be something that you're going to have a discussion with your EMR about. Are they, how are they planning on implementing OASIS, and will it be in the same format as the form, or are they restructuring it to better accommodate how they already have things in that, and your OASIS, your coding items. Here's a big section, swallowing and nutritional status, section K. Your M1870 has moved from the functional items here, but and your height and weight has also been moved here. But we've also added a K 0520. You have some at starter care, resumption care, and you have them also at discharge. And so on admission for your starter care or resumption of care, you're going to mark, does the patient have any parenteral or IV feeding? Do they have a feeding tube? And if so, it could be nasogastric or PEG. Mechanically altered diet. Do they have pureed foods or thickened liquids that require a change in that texture, liquid foods? Here's a big one, and almost all of our patients are going to have it. Are they on a therapeutic diet? And if they're on a low sodium diet or a cardiac diet or anything like that, we will need to mark therapeutic diet here. On discharge, it asks the same questions. They wanted to know, are any of these present at discharge, and are any of these, were any of these present also in the last 7 days? So maybe the patient had TPN in the past 7 days, they discontinued the TPN, and now they don't have it. So they had it in the last 7 days, but they don't have it at discharge. So you're just gonna check all that apply on that. The next item is your skin conditions, section M, and really nothing much has changed at all. M1311, really M1306 is the only thing on your research. No other M items for wounds are on your research. I'm sure your wound man will still be there and all of those things, but all of the M items besides M1306 have been removed from the research. Again, no changes to any of the verbiage of any of these items. Medications, section N. Again, 2016 is going away in 2016, but they're adding an N0415. Again, an item I really like. So this is your high risk drug classes, and especially for outsourcing companies like ourselves, you know, we see agencies that have all different kinds of high risk medicines. Some may be using ISMP, some may be using JCO, some may have their own list of what high risk drug classifications are. And so this question is asking, is the patient taking it? And if column 1 is chosen, is there an indication noted for all medications in that drug class? So they're going ahead and listing out the drug classifications for you: antipsychotic, anticoagulation, antibiotic, opioids, antiplatelets, hypoglycemic, including insulin, or is it none of the above? Section O is special treatment procedures and programs. Again, M1030 is going away, and they're expanding it into the section O for special treatments, procedures, and programs. And so this is if the patient has it, not just necessarily if they have it at home, but are they doing it? So does the patient have chemotherapy? And if they do, is it IV, oral, or is it some other kind of chemotherapy? You're going to mark if they're doing radiation. If the patient has oxygen, is it continuous, intermittent, or high concentration? If the patient has suctioning, is it scheduled or is it PRN? Do they have trach care? Do they have a ventilator, an invasive mechanical ventilator? Do they have BiPAP or CPAP? If they have IV medications, what kind of IV medications are they? Vasoactive, antibiotics, anticoagulation, or other? Are they getting transfusions? Are they getting dialysis? If so, is it hemodialysis or peritoneal dialysis? If they have IV access, is it peripheral, midline, or central, or do they have none of these? And you can mark none of the above. M1041, 1046, just formatting changes. 1051, 1056 have been removed, and just formatting changes M2200. I was a little disappointed that this was still in there, since it really doesn't lend any value unless the Medicare Advantage is somehow calculating a HIP score based off of your M110 and in your M2200. Section Q is your participation in assessment and goal setting. And you can see 2401, really the only change is they took the diabetic foot care out at discharge. All of the other process measures are in there except that one. And just some miscellaneous items, and then I'll answer any questions that anybody has. Social determinants of health is a big hot topic right now. And you can understand why. We talked about it even with conditions of participation, that those social determinants of health should help drive an individualized plan of care. If I have a patient or I have two patients and they both have congestive heart failure, one of them has, unlimited income. They don't have any problems obtaining medicines. They have great family support. They have, daughters, sons that come and check on them, help with meals, all of those kind of things. It's much different than another congestive heart failure patient that's on a limited income, has trouble buying medicines, and has no support system at all. Those two care plans should look totally different. And so we have to start making individualized plan of care. What does that have to do with OASIS? It really kind of has a lot to do with it. So think about the outcomes for these patients. Now we can start trending on OASIS. If this patient had trouble with transportation and compared to another patient that didn't have trouble with transportation, did they have the same kind of outcomes? This is especially important with dually eligible enrollees, those Medicare, Medicaid patients. They often have problems with social determinants of health. They may not have ready access to health care. Maybe they have some mental health conditions and again, don't have easy access to those mental health providers. So all of those things are really important as you're answering all of those social determinants of health questions, along with any of your behavioral questions also. The focuses of CMS in general is population health, reduction of healthcare spending, and patient and caregiver satisfaction. Some past initiatives, they've focused on increasing access to healthcare and treating medical conditions, and they're still responsible for all that and still concerned with all that. They're really working at trying to figure out the best method for patients to have optimal outcomes without extra cost. I mean, we're all in the business, right? So we all have to live in our means, and CMS is no different, but they also want good outcomes for those patients. So how will OASIS-E be used? It'll be used in your PDGM functional grouper scoring. It will also be used in your HHQRP measures. You'll have some star ratings on Care Compare, and then some of these items will also be built into your value-based purchasing that will be coming along with OASIS-E. Some PDGM items for OASIS-E, as far as we know, they're going to continue to contribute under these unless something comes out in a proposed or final rule. Will still be these items. At one point, they talked about the GG items, but they also knew that they had not collected enough information from the GG items to do away with the M1800 items, even though some of your post-acute care cohorts, such as skilled nursing facilities, their functional is dependent on their GG items and not their M1800 items. Some 2022 HHQRP measures that are claim-based is going to be your acute care hospitalizations, your discharge to community, your EDUs, your Medicare spending per beneficiary, and PPR, potentially preventable 30-day post-discharge readmission measure for HHQRP. For your 2022 HCAPS, you see your how often did the team give care in a professional way? How well did the home health team communicate with patients? Did the home health team discuss medicines, pain, and home safety with patients? How do patients rate the overall care from the agency? And will patients recommend the agency to friends and family? A lot of these claims are a lot of these items are going to be part of your value-based purchasing outcome payment that will be decided from 2023. Your OASIS-based measures are all listed here. Transfer of health information is one of the ones from your OASIS-E that will be added, but we still have the timely initiation of care, pressure ulcer, oral medications, influenza drugs, dyspnea, drug regimen review. All of those things are still in play. I wanted to just kind of put this slide together to say, really, these are the only M items required by CMS. Again, your EMR may be totally different, but this is all that's going to be on your research. And so we'll talk in a minute about what does that mean. So if we look at M80, the discipline completing OASIS, that really doesn't take an assessment. You should know what discipline you are. Your M90 date, your assessment reason, is it a recert? Is it a discharge? Is it a start of care? What is it? Episode timing. And then you have your M1800 items, your M1033 for your PDGM. Right now, there's a few GG 130 and 170 items in the M1306, and that's it. That's all of the questions that are OASIS driven on a recert or other follow-up. So think about the productivity points you may have given to your clinicians to do this reset cert. Now say that in caution, because again, your EMR may decide to leave all of these items in there and instead of taking them out. It's really going to be dependent on your EMR. So don't go rush and change your recert points that you've given for productivity if truly the EMR is going to make you answer more questions. So again, in preparation, we want to check with the EMR to see how they're formatting the OASIS as written, or is it for the flow of the EMR or assessment? I cannot tell you how important education is going to be this year between OASIS-E and learning OASIS-E and learning value-based purchasing. If nothing else, those two things should be at the forefront of the education plans you have for the rest of the year. I would say at least July forward, which is just next month. It seems like it should be a lot longer, further out than just next month, but July is just next month. So educate, you're going to have to put a lot of education into things like the BIMS and the CAM and the proper way to do it. How are you going to make sure that the reconciliation of medications is happening and happening in a timely manner, and who they need to go to? All of that needs to be decided before you educate, but certainly as you educate. You may need to look at your policies and procedures. And you certainly want to tune into the next series in the webinars, because Arlen's going to talk a lot about some things you may need to put in place for some of these items. Again, start thinking about the processes that may need to be put into the place to ensure your compliance and communication. And then, like I said earlier, there may be possible productivity standards. Now, I talked a little bit about the research maybe being decreased, but also we've added a lot of items to start of care and resumption of care. So maybe you're just reordering what your productivity looks like. And remember that there are so many new items with new assessment things that they have to do, that the learning curve will probably be pretty great. And so they'll be slower in the beginning than they will be once they get used to SOC Blue Bed. Some of your disciplines may be less comfortable. So let's say, I'm just going to say, maybe your therapy is less comfortable doing those social workery things than, say, a clinician would be. So make sure that all of your disciplines that are doing OASIS assessments are comfortable with all of the new items. I put up here one of the registration links is going to be in 2 weeks for the policies, procedures, and ponderations. Gain insight and tips into the mood, medication, and special treatment sections to ensure your agency is aware of needed training. Agencies will recognize where policies and procedures may need development to tackle these sections as well. And then we don't have the link up yet for the July 21st, but it'll be finding the value in OASIS-E. And this webinar will demonstrate how OASIS-E data is used when defining your agency's quality portfolio and performance scoring for value-based purchasing. Learn which items are used in these programs and why accurate data collection is imperative to agency success. And then we have the Learning Solutions Department, and they'll be offering customized agency OASIS-E training. And there's the link for them. And if you say, oh, I can't remember that link, that's too long, if you'll just shoot me an email that I've added on the next slide, then I'd be happy to get that over to the Learning Solutions team, and they can reach out to your agency for any questions you may have. And with that, I will open it up for questions. I see a lot of Q&As and a lot of chats, and I haven't looked at it to see what's in there. So
Wonderful. Thanks, Janan. Great information. So I'll just run through the chat, starting with the first question we got. And the first question was, do you have the administrative burden today for comparison? I know you touched upon that a bit.
not what the what it takes now, just the number of items that were added in addition to what they were.
Perfect. Thank you. And then the next question is how to respond with health literacy with a dementia patient.
That's a really good question. And I don't even see, I haven't even memorized all the responses yet. There may be that may be one of the items we can dash, but I would have to look at those to make sure. So if you want to email me that question, I'd be happy to look it up for you.
Thanks, Janan. Okay. Being that delirium is considered a medical emergency, would it not be important for home health agencies to have policies in place to guide the clinicians as to what they should do if a patient is assessed positive for delirium?
I think that's going to be covered in the next one, but I would assume that you would need some sort of policy to follow through with any irregularities you find in an assessment.
Wonderful. And then the next question is, do we have to follow up on routine discharge patients if they were on any anticoagulant medicine? I said that all wrong, but.
I'm not exactly sure what that question means, but as far as medication reconciliation, we have to do medication reconciliation. If you're asking, do we have to follow patients after discharge if they're on anticoagulants? I mean, I think that would be an agency decision. Well, you do have those 30-day readmission patients that if they get readmitted to the hospital, that they put a ding on your record. So that may be part of that question. I'm not sure.
Perfect. And then the next question was, Section O, is this for treatments received in the home or anywhere?
My understanding is it's anywhere.
Thank you. All right. The next question is, in case I missed what you said, the GG items are not currently being used for star ratings or payment, but they are used for anything else? Question mark. I think they meant, but are they used for anything else?
They're used as part of the Impact Act and CMS collecting that data. Currently, they are not used for payment, but CMS has said they're not used for payment for us because we didn't have enough data to make it correlate yet with the M1800s. But CMS also pays skilled nursing facilities off of those GG items. And so my guess is at some point, those GG items will be used instead of the M1800 items for payment. That's just my guess. CMS didn't call me on the bat phone and tell me that. That's just my guess.
Wonderful. What if on a recert diagnosis, what has changed on a recert diagnosis and has that been updated?
I'm not really sure of what that question is, but for the OASIS itself, the M1021 and M1023 section will not even be part of the OASIS unless an EMR decides to put it in there. You can certainly change what your focus of care is at research. Patient can have a new diagnosis. They can have a diagnosis taken off. So diagnosis can change all the time. So if you did a start of care, maybe your focus was a CHF, but now they've had a COPD exacerbation, that needs to be your primary diagnosis. So diagnoses are changing all the time. It's just because they're not necessarily pulled from the OASIS for payment, they're pulled from the claims. It's EMR specific how the claims are grabbing that information. I hope that answered your question.
Thanks, Janan. It doesn't look like the OASIS items for a recert will come anywhere near a comprehensive assessment for COPs, does it?
Remember, the OASIS portion is not your comprehensive assessment. Your comprehensive assessment will still have to be done. It's the data points from the OASIS that will be collected at research, but you'll still have to do a comprehensive assessment.
For the research, you mentioned that there is no more diagnosis part in the OASIS-E. How can we show the change or update in a patient's condition? And how will the care plan be generated this time? Will it just pick up the initial diagnosis from the start of care?
No, it'll be EMR specific. So some EMRs may decide to keep M1021 and M1023 in the body of the OASIS. However, it's not required. So it would be up to the EMR of how to pick that information up of the diagnosis changes. Like some EMRs have a separate section that's the diagnosis section. They may pick it up from that section to go to the plan of care. That is all going to be EMR specific.
Wonderful. Did you say or have any idea when the final OASIS-E will be available to view?
The draft comment period ended April 11th, May, June. It's usually at least 60 days that CMS reformulates it, and then it goes to the OMB for approval. So I'd say the earliest it would be is going to be somewhere around mid-June, but my guess is probably closer to July.
Okay. And what are your thoughts on automating a workflow like OASIS?
I haven't thought anything about that.
Excellent. Excellent. And then given the new focus on hearing, will surveyors potentially be looking for solutions to any problems identified, such as closed caption phones?
My guess is surveyors will be using a lot of these items for translation, because you got the preferred language in there now. I think they're going to be looking for all of those things. Yes, that's my opinion only. Again, they didn't call me and ask me my opinion, but that's my opinion. I also tend to think that everybody's a conspiracy. You got the surveyors over here, the Macs over here, and everybody's looking to get us. So.
All right. Who is responsible for doing the medication reconciliation when a PT is discharging the client?
The COPs haven't changed. The nurses still have to do the medication reconciliation, which is why you even need to think about that process even more, because if the PT does it in the home, you can't leave a reconciled medication list, because PT technically can't do that reconciled medication list unless something changes. I don't think it will, but it might. Sometimes we have COPs in the proposed final rule. So we'll see.
Excellent. Well, that answered all of the questions, Janan, that I think I'm just going to double check the chat. Just one last question in the chat. With the changes to the cognitive questions in the OASIS-E, how will cognitive exclusion be captured?
I'm not sure the question. Are you saying that the patient's not cognitively able to answer? If so, I think there's one that says unable to respond.
Perfect. Excellent. Well, I think those are all the questions, Janan. Thank you for a wonderful presentation.
Sure.
As Janan said, we are going to have more webinars coming up. This webinar was recorded, so look for an email and next week with a link to the recording so you can go back and view it. If you need the handout, I've seen a lot of you send me emails. I will be responding those shortly with the handout. Like Janan said, we will be offering training on OASIS-E. So if you need training, be sure to reach out to Janan or myself, and we would love to help you with whatever your agency needs. So Janan, great job. Thank you so much.
Thanks so much. Goodbye, everybody. Have a great day.